Welcome to this video showing a completely endoscopic aortic valve replacement. My name is Joel Dunning and I had the great privilege of being invited to AMICS, the Minimally Invasive Cardiac Surgery and Surgical Arrhythmology Conference. This was held at the Vishnevsky National Medical Research Center, organised by Amran Reshvili. And it really was a fantastic conference. They had twice daily live operating and they had a stellar guest list. And I was completely blown away by this case by Alaaddin Yilmaz, showing this totally endoscopic AVR. So I'll hand you over to him. He'll do some narration and we'll show you the whole operation.
Good morning, dear colleagues. Thank you again for having interest in this interesting case. I think you already have heard the patient's history. Young patients with severe aortic valve incompetence, and it's a bicuspid valve. I think it's I don't know if it's really post-endocarditis, but anyway, there's a prolapse of the I think it will be the left coronary cusp. This will be a totally endoscopic aortic valve replacement with a stented valve. Because he's young, we will place a metallic valve. We will start with the groin cannulation and then we will go on with the endoscopic approach. I still have some few minutes to prepare everything and then we will come back to you to give you the endoscopic view intrathoracic.
So Alaaddin then proceeded to perform vein cannulation. First of all, he proceeded with femoral arterial cannulation, passing a wire and then passing the arterial cannula. After this, he then put a second wire into the femoral vein and under echocardiographic guidance followed that with a smart cannula up into the right end atrium, again confirming on ultrasound. He then places his access utility port and 3 5mm ports, and prior to coming back to the conference he just opened up the pericardium just using a standard diathermy and a standard endoscopic instrument. He removed a little bit of the thymic fat on the right and then widely opened about a 4 centimeter size incision in the pericardium, and so back into the operating room.
I'm now on the groin cannulation. You can see it here. We use the smart cannula for groin cannulation and a 19 French arterial access. And we already had made our incisions. You see there are in fact 4 ports. These 3 are 5mm ports, and this is my working port of my finger's width. Nothing else than this, and so no larger incision than my finger width. My finger width is necessary to put my knots. And if you will go inside, so the heart is still contracting, and I've already opened a bit the pericardium. And next step will be to access the heart, let's say the aorta, by putting stay sutures at the pericardium. So you see the aorta over there. This is the right atrium. The pulmonary artery will be on the left side, and you see I can see the right ventricle perfectly without any problems. The thing is that you should have enough sites on the working area that will be in this case the aorta. So once the aorta is opened, we will put stay sutures. I just put 3 stay sutures, and you see my incision on the pericardium is about 3 to 4 centimeters large, nothing else than that. That makes that post-operative my adhesions will be also less. So in case you might need a re-op, that will make that your incisions, or let's say your working area, will have very few adhesions, and re-op will be as easy as your first case. So these are the simple retractions we will always put on the pericardium. In total it will be 4, 3 on the lateral side and 1 above. I will try to put them as quick as possible, so you might see when I start or when I try to arrest the heart. This patient has an incompetent valve, about grade 4 severe, so we need to give selective cardioplegia. Some say when you do endoscopic surgery, selective cardioplegia, when in case of incompetent valve, it's dangerous, it's impossible, don't do it. But of course, it's perfectly possible if you know the tricks, how to do it. So, this is my second retraction suture. Simple stuff, not expensive, everyday stuff, let's say, cheap, and you can do it in any case, in any center you want to do it. My second is put in place. Naaldvoerders. So this will be my third one. And you see, once I put my stay sutures, the sides on the working area of the heart gets more and more accessible. It's all about the view of your heart. This is a simple suture retractor needle. It goes percutaneously, transthoracic. Yeah. So in aortic valve cases, you always have to think about venting the heart. And it's endoscopic on the right side, so my venting will be on the right upper pulmonary vein.
Excuse me, Alaaddin, could you please also give a few comments about venous cannula? It's so unusual in our country.
Yeah, normally I always use the Medtronic multi-stage cannula, but it was not affordable over here, so we have chosen for a smart cannula. I think you might know the smart cannula. I think it's the best cannula for having easy way of drainage of the venous blood. You can put it very easily percutaneously. I put it phenolprolane through a small groin incision, and you don't need any extra. I think with gravity alone will be enough to empty the heart. So this is my purse string. Again, it's endoscopically performed on the pulmonary vein, upper pulmonary vein. So this is a 4 proline. Even just pulmonary vein, right? Hier hogerop. Zo. Ja. If there are any questions, please ask, so I can answer them.
Maybe when you are working, you let to Pascal to give few comments about perfusion.
Yeah, my perfusionist, before we start always, there's communication with my perfusionist, and he is well dedicated minimal invasive perfusionist, I must say. Any case we start, we always discuss on which cannula we should use and on what way. And I think he's the main team player in this team approach. It's not only the surgeon's case, of course, it's a team approach. So maybe he can give some
good morning,
comments
Pascal.
necessary.
Yeah, this is a camera. Could you please tell a few words about your pump set, about perfusion right now?
Okay, the pump is a conventional system. Yeah. At our home place, we always use minimal invasive extracorporeal circulation. We use a small circuit, but it was difficult to get them through customs. So what we have here is just a roller pump. We have a normal reservoir. We have a conventional ECC with vacuum drainage, and basically just we have two suckers. We have a cardioplegia that we use. Is different. We use a modified Del Nido. The thing is that because we use minimal extracorporeal circulation, it's difficult if we dilute the patient. So what we do is a 3-to-1 base. So modified Del Nido, single shot, up to 2 hours, and we dilute the patient with 250 mils. So this is at our home place perfectly doable then with our minimal invasive extracorporeal circulation. And also it's difficult if you use Calafiore in minimal invasive setting. Let's say if you do endoscopic mitrals, we just go for single shot and that's it. So still we brought the cardioplegia we are used to, so we brought them along. So today is also a little bit of a modified Del Nido, single shot. We have to see, because if it's an aorta insufficiency, we'll see how much we have to give, but basically it stays the same, 3-to-1.
Right here from this side.
So this is for the cardioplegia part. This is a heater cooler. We give it at 8 degrees. Then we have double head pumps there. So 3 parts of blood, 1 part of crystalloid. As I mentioned, single shot up to 2 hours. So easy to administer.
Could you please give some comments about your cardioplegia, what you usually do in Hasselt?
Excuse me.
That's what I mentioned. This is just 3 to 1, modified El Nido, single shot, up to 2 hours. That's it. Less hemodilution, easy to give. So that's the thing. You see also here is the reservoir. This is the roller pump, and we use a little bit of vacuum for assisted drainage. We have the smart cannula, which is quite similar to a stent because it wasn't portable to use the multi-stage here, which we often use at our home place. So basically, this is, in a nutshell, the perfusion.
Thank you so much, Pascal. Thank you for your nice job. And now we are ready to switch to the surgeon.
So what I have done is I've put my left vent through the right pulmonary vein. It's on place. And now it's time to arrest the heart. Aortaklem. Rechts een beetje leegmaken.
So we are ready for venting the ventricle.
The ventricle has already been vented. The vent is over here. It's placed through the small 5mm port. And I will also use this 5mm port to put my clamping.
Okay, so we are ready for arresting heart.
Yes, so my clamp is placed. Zeigers. We always, when I put my clamp, we have to check my left appendage.
So that's a great view.
So it's free. Okay, terug. And upper is okay. Yeah. Now clamp is set in place. I use a small 14 gauge needle as yesterday.
You do it yesterday percutaneously. Now
Here not, it's through that small incision.
Okay.
Vent even stop. Vent aan, de groene. Okay, plegie aan. So, thing is with this patients having an incompetent valve, how we will give selective cardioplegia. Is goed, is goed. Zuiger en de pincet. So I stopped the venting of the left ventricle, and while doing that we give cardioplegia. Since the heart is contracting, it has enough power to eject or having no problems with dilation. And once he gets, let's say, slower, or we see changes in his ECG, then we will stop and we will vent and give.
We can see these
selective
changes at the echo screen.
On the ECG, there's still his sinus and contracting, so we'll have enough time. And you can see also, look to the right ventricle and the left ventricle, there is no dilation, so in this case we can go on with it. Vent was stoppen.
What is the diameter of this cannula in aortic root?
This is a 14 gauge.
Quite
Small.
small.
Very small. So now it's almost stopping. On ECG we have a slowing of the rhythm, and I ask always if there's dilation or not of the ventricle.
You routinely use this kind of plegia at your
Always.
home bed?
Always. We use just this cardioplegia.
How many times it takes for your job? How many times it takes? It gives you to work with the heart.
What do you mean by how many times?
When we should to repeat the plegia.
Oh, the repeat is almost none.
So
Almost none. It's 2 hours without any problem.
just one shot for
One shot for
the
almost
whole
all
operation.
operations. Yes.
So thank you, sir.
Yeah, I see. Yes. Okay, vent of the left ventricle. Stop, plegia. Groen mag blijven zuigen. Huh? Now we stopped administering the plegia, and I will go on later on for my selective. So zuigen voor mij. I don't go, I just wait till the heart is very totally empty. Groen blijft zuigen, hè?
Oh, that's the roof.
Yeah. So once the aorta is, let's say,
What do you
empty,
say?
then
Is
open
it
it.
necessary to give some plegia through the ostia in this case?
I will give,
Or
I will
maybe
give. I will give.
it will be enough from the root?
Yes, no problem. So coronary sinus reperfusion, I don't believe in that. Not necessary. It's also expensive, but I'm just waiting. Rechtsleger, kan dat? Now it's getting empty, you see?
Yeah, sure.
I'll wait till it's totally empty before opening of the left ventricle. Don't hurry. Makes no sense to be hurry. Now it's getting empty. So maybe I will open it. There was some blood loss, no problems. So next step is opening of the. So. Yeah. Yes. So I open my aorta at the spot of my puncture. Yeah. Will bleed a bit, let's say, but anyhow not much then. Hans, even zuigen eruit. Rechts leger alsjeblieft. Now it's nice empty, but my scissors, yeah. Ja, oké. Zuigen die andere schade even naar mij. Ja, duw dat weg. So I will open further the aorta. Yeah. It's all endoscopic instruments from now on. You can easily see the aortic valve over there. So next step is putting some stay sutures. 4-0 probleem, mag weg. Yes. 2 stay sutures are enough to give access to the heart. Just ja, is leeg, dank je. So, simple sutures on the aortic valve to lift the valve up so that we can administer our plegia. Ja. Volgende. My second stage, even terug. So always use your pericardium. For the retraction.
Today you choose venting the left ventricle through the pulmonary vein.
Yes.
So is it possible to do some another ways for venting the left ventricle?
Yes, we can, let's say on mini bentals, mini surgery of the root, then we use the venting of the pulmonary artery.
But you do it through the upper sternotomy?
Yes.
Yep.
Now the positions, we have better sight now, the plegie. And we will give plegia through the coronary osteas. That's good, sir.
What do you think about contraindication for this type of access
No,
to the aortic valve?
no contraindication. Kom het erbij? Ja. So, there's my left coronary ostium. Ja, plegie. And we can administer nog 300 extra. So you can see the view on the aortic valve is perfect. It's better than open view.
Yep.
Because of my endoscopic augmentation of the view, it's 10 times larger, bigger than our eyes, and we can go macroscopic inspection of the aortic annulus without any
Oh, we
problems.
can see the flush from the right ostium.
From the right ostium, there's some flush also. Yes. There are
As
some
far
connections.
as I understand, we have a very great view,
Yes.
absolutely dry field.
Yes. The idea of minimally invasive surgery means as less hemostatic as possible without losing much blood. So the blood loss during minimally invasive surgery is much less than open surgery. That's for sure.
Yep. But as for my opinion, sometimes we have cases with a heavy calcification of annulus and also ascending aorta. Is it possible to do such cases from this access?
Yes, we can do it. Then what we do, if it's not porcelain aorta, then I use the sutureless valve of Livanova to put in the annulus. Of course, that's easy to put in such kind of calcified annulus.
Okay. I see, sir.
Root.
I see.
Yes.
So what can you see about the valve?
I will first wait by administrating the plegia, and then I will inspect the leaflet. But I can see there might be a small cleft or perforation, but not a big thing, but enough to have a important.
What we saw on echo, that was quite big prolapsing of one of the cusps.
Yes, we will see when I empty the roots, then we'll see much better.
So it was a few months ago endocarditis, so the ventricle is quite large right now.
Yes.
So I think we have to make decision
to replace
very carefully.
Yes.
So Alaaddin has given cardioplegia to the left main, and he now placed the selective plegia into the right coronary artery. And I just sped this up a little bit just to get through this. And then also he did a great job of a few retraction stitches, and the right atrial appendage was just getting in the way. So he just used the pericardium and a suture to just retract the right atrium out the way a little. And then once he'd done this, then he was ready to get back and have a good inspection of the valve.
The heart, we are now inspecting the valve. What you've seen is it's like a bicuspid valve, because the right cusp is very large, smaller non-coronary cusp, and there seems a bit slight prolapses of the right coronary cusp, as we've seen on the pre-op echo. So there will be some discussions about what to do in this case. Some might say, okay, let's try for a plasty. Others will say it's a bicuspid valve, go for a replacement. But I think we will do a replacement because there's high suspicion of endocarditis. In my personal small experience, I have not much experience with giving repair of post-endocarditis bicuspid valves. So I don't know what the audience might think, but we will go for a replacement of the valve. So what we do, we use a normal classic endoscopic scissors to take out the valve. There's still some bleeding from the right coronary ostium. Anyhow, it shouldn't give any problems. Just by simple scissors we can take out the valve. This is the right cusp. Second kijken. Yeah. Now we would look from the other side to check for the resection. This is my left coronary cusp. It's an easy way to resect again. If there are questions, please ask me. This is the left, and now the non.
Вот, уважаемая аудитория, пока доктор проводил кардиоплегию, я ему задавал несколько вопросов. Существуют ли какие-то ограничения в селекции пациентов для такого доступа к аортальному клапану? Ну, доктор Алaaddin заявляет, что нет, он выполняет такой вид вмешательства не только при вот.
Now we will size the valve. my sizer gets just through my incision. It's a classic sizing. 23 is too small. I think it's a 25 valve. Yes, it's perfect. So we will go for a 25 mechanic valve.
Okay, sir.
Yeah. The Hechtinger. The sutures, I will put one suture and you will see how it looks like. It's normal surgical sutures like an open surgery. And we use a Etibond 2.0 with pledge for that. Zeg maar. Zeg maar weg. Zeg maar weg. Yeah, sure. Yeah. So my needle goes in the root. Just simple sutures. Yeah. You can see very nicely the commissures and also my depth of my sutures also very easily. This is of course a case with non-calcified annulus, but I like calcified annulus more than non-calcified because then it's easier. It's my opinion.
Just before you, I said a few words about that. So maybe you can talk about the choice of type of valve. So
in my
what do you prefer usually?
I prefer usually to put biologic valves, even in young patients. When you talk to them about the quality of life, having no comodines post-operative, I must say they all choose for a biologic valve. And that makes sense because of the surgical access. This is endoscopic surgery, and even a second surgery will be as easy as this first surgery because, as I told you, the adhesion will be almost non-existent. And I think when a patient has no comodines in his life, even when he is young, his quality of life will be much better than having comodines. So that's my whole idea.
That's a great point.
So normal sutures as an open surgery.
Do you have
Я
any
думаю, нам надо
experience?
двигаться уже к следующей сессии, а то по времени мы уже задержимся сильно.
Да,
Спасибо
хорошо.
всем участникам
Спасибо.
этой сессии. Мы не будем, наверное, комментировать все доклады. Переходим уже сразу к следующей.
Okay. Offline?
The session is closed now,
Uh-huh.
so they switched in 15 minutes, and then we will go again online.
Okay, perfect. That's my idea about valves, and I think even 20 years patients in my case, they
We have
choose for a biologic.
25 regions, so
Yes,
it's it's a nice choice for
Yeah.
these patients.
yeah, sure. Yeah.
Trust me, this is the only clinic in Russia where we have regent.
Me?
That's because of our
Доброе
chief
утро,
regent.
уважаемые
Others?
коллеги. Мы еще
Another we
вернемся
use
в
Russian
операционную.
valves like Medinch and something like that.
Приглашаю,
Is it? I didn't know.
You even don't see this valve in
приглашаю,
Europe.
значит, Фрейзера, профессора Фрейзера, Островского, Михаила Гордеева и Тора Эдвардсон уже с нами. Здоров.
But is this video still running there or not?
No.
It's pity.
Uh,
They should leave it running so
there
that
is there
others
is there
might
is
look to
there
it.
is there is changing the chairmans in the audience room, so we will be online few minutes later.
Okay.
So the conference couldn't stay with Alaaddin for the whole case because it's a busy schedule, but we have recorded the whole case, so I thought it was important to show every single stitch because every single one was put in with immaculate vision, really good endoscopic view, probably even better than an open view. And just for the sake of time, I've sped it up 30%, so I'll leave you to watch every single suture going around the right coronary cusp, then then left coronary cusp, and then also insertion of these sutures into the valve. Then we'll join Alaaddin again, where he'll drop the valve in and use core knot to tie the knots.
So we have put the stitches through the valve, and inside it looks like this, normal sutures through the annulus. And now it's time to push, push the valve through, mesh. So, as I told you, my incision is as big as my finger's width, and that's enough for, I think, all valves. I even put 29 valves, and you see, you would say it's impossible to push this valve through this incision, if it's hard, but you should slip the valve aside like this, and then it's much easier to push us through, you see? So even 25 valve with my finger width will be easy accessible to the root. Okay, is that for me? So next step is to push the valve inside. Because it's mechanic, I will try not to harm the valve itself, so I will try to push it very slowly. And then a biologic valve is easier because you have much more tissue to hold with your forceps. So I will use just my van boven kijken sewing cuff to put my valve aside, let's say inside the annulus. Alright, that's it. Slide on the right, commissures. Push a bit downwards this side. Yes, you see very nicely if my valve is on the right spot or not. Sometimes with open surgery you don't see it, but the scope itself helps you a lot, you see. Now I just have to put my stitches, let's say not my stitches, maybe on the left side, even terug. I have to push it a bit down here for left coronary. So when I put my stitch, let's say not my stitches, this should go down the left coronary. So I will start first with my left and go to the right and end with the non. For knotting it, I use the well-known core knot device. In this case, I would first start with the middle. Yeah. That's it. Let's check how it looks like inside. Goes good. You see my knot was here. Next step will be the blue, other one. Cinemark. These two. Yeah. So we push it downwards. Okay, pincette.
Okay, Professor Alaaddin, a core knot is really helpful to do this, no question
Yes.
about. So we should continue here. We'll come back when you try to close the aorta.
Okay, perfect.
Thank you
All
very
right.
much. Thank you.
So we've again left the conference as they do further lectures, and again I've just sped up the view, but I did want to show you how quick and efficient the core knot was, and also the immaculate view you get endoscopically as you push down the knots. Alaaddin's able to give good firm pressure with the core knot and actually see the pledgets pull back and retract behind the valve leaflets to keep them absolutely safe, so there's no chance at all that they could get stuck. And you can just see there beautifully in the ventricular outflow there, the pledget pulling back. And so he uses the core knot for every single suture. I've missed a few of those out, but they are all very easy, and having a suture organizer outside as well is obviously vital, and checking every single stitch to make sure no mistakes are made. And here's just the last one, and that's beautifully placed. as you can see, the leaflets of the valve moving freely. So then he proceeded to close the aorta with proline suture using a horizontal mattress technique, and then a second layer of simple sutures, and then some bioglue for a third piece of strength. And again, I'll just leave you to watch this. I thought it was really fantastically done. The view was perfect, the same or even better than open, especially the aortotomy right down at the annulus of the aorta. It's absolutely fantastic, unparalleled view there, where sometimes in open surgery it can be difficult to see. So I'll leave you to watch this, and then we'll come back once the aortotomy has been closed, and Alaaddin will just give a short narration on restarting the heart and closing up.
простых людей с
Beetje vulling even,
Да, вот
Pascal.
эта вот девочка, которая была прооперирована
Beetje vulling. Heb je dat?
сколько-то лет
Kan je dat?
назад,
Oh,
у нее все тело
3,5 liter uitgehaald.
татуировками. Не пытайтесь перевести, дорогие коллеги.
We will give some extra filling, Medina, then you can see better.
Большое спасибо, Алексей
Если они
Олегович.
наполнят сердце.
Да, наш самый. You have a sinus, heart is beating, everything looks good. What
Yes,
about
we will.
the echo?
We will fill the heart a bit so we can see the echo. Can you go to the echo?
Дайте нам эхо.
Картинку, эхокардиографии.
Meer filling? Yeah. Is
Okay, now
okay,
it's
now-
much better. It's clear.
Yeah. Bit filling. Medina, you can look to the valve, please. Now you see the valve over there. What you see over that's a circular thing. That's in fact the cannula. Venous cannula we used. It's projecting almost in the aorta, let's say, but it's not. It's in the right atrium, as you can see over here. Yeah, it's there. Some color, please. So it looks okay. Next step is take out the vents and close everything.
Okay. Okay. Thank you very much.
Thank you.
Alaaddin, we applaud you. Давайте похлопаем Алaaddину, прекрасно он
Thank you.
поработал.
Well done indeed, Alaaddin, for this amazing operation, and thank you, Amix, for allowing us to present this operation to you. I think you'll agree it was absolutely amazing operation, and we'll just leave you with the final closing sutures and decannulating. Thank you very much for watching, and please do make comments if you find this interesting or have anything that you'd like to say about it.